Next, I call upon Dr. Suresh Kottegoda to talk about an area where it can be sometimes confusing because diagnosing, looking at the ECG and saying is this atrial fibrillation or not can sometimes be not as easy as we think. So over to you, Dr. Suresh Kottegoda. He is, of course, the consultant cardiac electrophysiologist at the General Hospital, Sri Jagannathpura.
Good morning, ladies and gentlemen. I'd like to thank the President and the Council for the kind invitation. Let's talk about the atrial fibrillation. Like most things in life, British writer Frank Atterbury said it's attention to detail that makes the difference between average and stunning. Here we go. So it's a all too familiar story in our aging population. 82-year-old gentleman with multiple comorbidities got admitted with an infection, chest infection, and went into AKI on CKD. And this is an ECG, as you can see, narrow complex tachycardia, and it's quite fast ventricular response. And one of the pitfalls can be when it is, this is atrial fibrillation obviously, and when it is very fast ventricular response, it can look deceptively regular. And it may well be, it can be diagnosed, falsely diagnosed as sinus tachycardia. And what we have to see is when the heart rate goes beyond, so the ventricular rate goes beyond 140, we have to think beyond the sinus tachycardia. And so beware of diagnosing atrial fibrillation only by looking at the monitor. Sometimes they call the electrophysiologist. I go to see the patient to see 12-lead ECG is not being taken. They have expertly diagnosed whatever, just by looking at the monitor. So important thing is to apply take a 12-lead ECG, put a caliper. And this is a 82-year-old lady who fainted in the bathroom, again, atrial fibrillation, but this is a part of sinus node dysfunction, where this patient's sinus node doesn't do its job, and rest of the atria have become hyperexcitable, and the patient gets atrial fibrillation. When the atrial fibrillation stops abruptly, the sinus node doesn't start, So and then there is a pause, and you can get cerebral hypoxia, and a patient can get a syncopal episode. And this is part of the sick sinus. This is a 64-year-old lady who came with recurrent episodes of palpitations, admitted with slurred speech, and MRI showed infarction in the cerebellum. And this is the ECG when we took it was, and as you can see, it's an atrial bigeminy, frequent episodes of atrial ectopics. That's what we saw. And these are the these are the most common triggers for atrial fibrillation. They are usually arising from the pulmonary veins. They can also come from the vein of Marshall, or pericoronary sinus, or superior vena cava, or crista terminalis also, but commonest is the pulmonary vein ectopics. When the Holter showed this, actually sometimes it can be falsely diagnosed as flutter. This is not a flutter. This is actually atrial fibrillation. It's a coarse atrial fibrillation. And as you can see, there is a flutter ECG which I have put lower down, and it's a very beautiful sawtooth pattern. Next case is a 44-year-old patient with a family history of sudden cardiac death, first-degree relatives, and he underwent this ECG. And this one, as you can see, it's a slightly wide QRS complex, not a typical bundle branch block, but it's irregular. And the salient features are the very tall, high-amplitude QRS complexes with marked repolarization abnormalities, as you can see. You can see arrowhead-like deep symmetrical T inversions indicating problem in the myocardium. And obviously, patient had a hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, atrial fibrillation is the commonest sustained arrhythmia. And it increases with age, and also it becomes commoner and commoner if the patient has outflow tract gradient, outflow tract obstruction. This is a patient who has had a MVR done, 58-year-old a few years ago, and coming with progressive dyspnea. And this, as you can see, there is a wide complex rhythm which is going on. And we might be falsely, it might be falsely diagnosed as ventricular tachycardia, but it is, as you can see, it's irregular. And the pattern is, it has happened after a longer cycle length, and it's long cycle length, short cycle length. So this is a type of aberrancy as a result of right bundle branch block, rate-related right bundle branch block. This is known as Ashman phenomenon. And it's particularly after, as I said, after a long cycle length, short cycle length, and you can get a rate-related aberrancy. It's a atrial fibrillation. This is a 28-year-old who came with difficulty in breathing, has had syncope in the past. It's a very irregular, wide complex tachycardia, this one. And as you can see, there is slight slurring of the upstroke. It's subtle, but it's there in most of the cases, most of the leads. And there's a clear positive V1. When it was cardioverted, it's a WPW with a short PR interval and marked pre-excitation. Again, a difference between that and a polymorphic VT is that this actually, as you can see, it's a very rapid, nearly 300 beats per minute, irregular wide complex tachycardia. Whereas Tossard will be, you will see, it will be about a twist. It's like a twisting morphology. It's like going around an axis, but that pattern is not there. But these are semantics. I mean, the management will be DC cardioversion either way. So there's not much point in mulling over it. Next is this is another patient with WPW, and there is no tall R in V1. That is, it's a left bundle branch block pattern because it's a right-sided accessory pathway. And clearly, it is not something. It is not something going down the AV node. It is irregular because it's a very fast rhythm, about 200 beats per minute. This is another type of atrial fibrillation, and this can be falsely diagnosed as a left bundle branch AF with left bundle branch block. But as you can see, it is not a typical left bundle. It's a left bundle pattern, not a typical left bundle, and there is subtle beat-to-beat variation in the width. That is as a result of variable pre-excitation that can occur as a result of variable conduction down the accessory pathway. This is again WPW. This can be commonly mistakenly diagnosed as ventricular ectopics, but it's you get subtle pre-excitation. This is intermittent conduction down the accessory pathway. This patient has most of the time this atrial fibrillation, obviously, and it might be difficult to appreciate the baseline oscillations. It may look a little flat, but it is still atrial fibrillation because it is irregular ventricular response. But most of the time, it seems to be going down the AV node, but from time to time, it does go down the accessory pathway, giving pre-excitation. This is another patient, interesting one. It was a 78-year-old lady who came with lethargy, drowsy, basically superosed when she was brought in. And you see irregular rhythm, but bradycardic, very slow ventricular response. Everything is slow and small. QRS complexes are tiny. And this is as a result of a very large pericardial effusion and atrial fibrillation. She had TSH, which was through the roof, severe hypothyroidism. Next one, 28-year-old with palpitations, with vague right-sided chest pain. What is the diagnosis? The key feature here is it may be difficult to appreciate P waves in some leads, but you can see the P waves and whole lot of baseline disturbance. Maybe patient was, shivering or air conditioned or some electromagnetic disturbance. So these are not atrial fibrillation. Obviously, this is artifacts. So, ladies and gentlemen, when it comes to diagnosis, interpreting the ECGs in atrial fibrillation, just keep it simple. Look for the P waves. Note the irregularity. Thank you very much for your attention.
Thank you, Suresh, for walking us through that spectrum of presentation, ECG presentation that can happen in atrial fibrillation.